All right, we will go ahead and get started. Again, I am Alexa Tinsley. I am the Director of Programs here at Jett Foundation. Again, appreciate you all being here today on our community webinar series on weekend dosing. It's something that we've heard a lot about in, conferences in the community about needing more education around weekend dosing, what it is, how to do it, if it's, if it's recommended, if it's not. So we are very excited to have Dr. Panda here today, or Dr. Veerapandiyan, but he also goes by Dr. Panda, who is a pediatric neuromuscular specialist at Arkansas Children's and also an associate professor of pediatrics at University of Arkansas for Medical Sciences. So Dr. Panda, thank you for being here, for helping us make this webinar possible, sharing your expertise with the community. Super important. So if you don't already know Dr. Panda, most of you do, but he is the co-director of the MDA Care Center and director of the PPMD Certified Duchenne Care Center at Arkansas Children's. And he also does a lot in clinical research and education. He's published more than 50 peer-reviewed articles, has presented work at national and international meetings, and he's also actively involved in clinical trials, including gene therapy, focusing on neuromuscular disorders in children, including Duchenne. So before we get started, I do just want to mention a few things. If this is your first webinar series, we do offer these throughout the year. After Dr. Panda is done with his presentation, we will be having a Q&A. My Zoom has changed. So there is a Q&A panel at the bottom of your screen. If it hasn't changed for you, it's two little boxes that say Q&A. If it has changed for you, it's now a box with a question mark in it. So if you do have any questions throughout the webinar, please go ahead and put them into there. We do our best to monitor the chat, so we do try to pull questions that come in from there. We are also streaming to Facebook, so we will be monitoring that and try to bring in questions from there as well. If for some reason we don't get to any, we will send them to Dr. Panda to see if he is able to answer them after the fact. This webinar is also being recorded through Zoom. It will be live later on our YouTube for you to be able to share for anyone who wasn't able to be here, or if for any reason you have to log off and aren't able to get all of the information, it will be there for you at a later date. So that's enough from me, and I will go ahead and hand it off to Dr. Panda. Thank you so much.
Thank you. Thank you, Alexa, and thank you guys for joining. Feel free to put your questions in, and I just want this to be more casual. So I know when Jett Foundation asked me to talk about weekend dosing, so I thought I would give you kind of brief introduction about steroids and why do we use steroids in Duchenne, and then kind of get into what do we know about weekend steroid dosing. All right, with that. All right, so we all know about Duchenne. I'm not going to get into details of that, but there's your early signs, there's ambulatory phase, early non-ambulatory, late non-ambulatory, and multiple stages. I think this is just to highlight that the corticosteroids could be helpful or could be beneficial throughout the disease course, throughout the lifespan of the disease course, right? So you have your early signs that may occur about age 1.5 to 2 years, and then as time goes on, they get into this ambulatory decline phase where you can have corticosteroids can preserve motor function, right? And then it can also help with your other functions like pulmonary and breathing and heart function in the later stage. We'll get into the details of the steroids that's out there that's available right now. But sometimes treatment as early as 2 years old can be done, like steroids. We have 2 steroids now that are actually approved for age 2 and older, so Emflaza, deflazacort, and vamorolone or Agamree. Obviously, we know the earlier diagnosis and treatment is better outcomes. All right. So why corticosteroids, right? So we have a large number of clinical trials and other studies that have shown that the steroids are beneficial. Of course, it comes with the risk, but the benefits is outweighs the risks. And in Duchenne, that there are short-term corticosteroids that has improvement in muscle strength and function. There is improvement in breathing. And of course, what we know is it slows down the disease process, right? It prolongs the ambulation somewhere between 2 and 5 years. And it reduces the need for a lot of kids in the past had scoliosis and need scoliosis surgery. It actually reduces the need for that surgery for scoliosis. It delays the onset of cardiomyopathy, the heart disease. It also delays the need for ventilation in kids with Duchenne, and also increases the survival. But there's a lot of data out there that can support all of this from a corticosteroid perspective. Now, so when one of the questions that comes up is when to start steroids, right? So it varies. So if you look at the current guidelines, they kind of talk about you start just before they start to declining, right? But obviously, you want to discuss the steroids at the time of diagnosis. You don't want to wait. Whatever age you get you diagnose your boys with kids with Duchenne, you kind of discuss that. So again, in the current standard of care, if you look at the guidelines, they talk about should be started before the child reaches the plateau. They improve and then they kind of go plateau, and usually around 4 to 5 years of age. But like I said, we have two steroids that's actually approved by FDA for 2 years and old. So deflazacort and vamorolone, right? And of course, we use prednisone, but it's not actually approved by FDA, but as we just use it. Now, the practice varies, like I said. I typically, in my practice, we recommend starting them around age 2. And then, there are some physicians who would recommend start around age 4. So it's going to, the practice still varies, but you can start as early as 2. And there are some, like Nationwide Children's and Dr. Connolly, sometimes there are studies that actually shown beneficial effects in younger kids, which we'll touch upon. When I say younger kids, 1 year to 1 year olds. There's different regimen that they used in the study. That sometimes that can be done also younger than 2 years. All right, so in terms of dosing, again, I'm not going to get into details. For prednisone, the standard dose, if you're using daily, would be 0.75 milligram per kilogram per day. If you're using deflazacort or Emflaza, it's 0.9 milligram per kilogram per day. If you're using vamorolone, obviously it's somewhere between 2 and 6 milligram per kilogram per day, but the recommendation is obviously start at 6 milligram per kilogram per day. I know this is just a typical regimen, right? And then the crux of this talk is going to be about the weekend dosing or the alternate regimens, meaning what are the different other types of regimens that are being used. Before we jump there, what are the doses? There are, even though there is milligram per kilogram per day dose, there's maximum dose, that we typically use in our clinical practice, right? For example, for this prednisone, we typically don't go above 36 milligram per day. But if you're using Emflaza or deflazacort, not more than 40 milligram per day. And then for vamorolone, there's actually guidance in the FDA. If you look at the FDA prescribing information, FDA label, there's guidance in the maximum dose also. And then if you're using the weekend dose steroids, there's also maximum dose that we go up to. And there are different calculations that people use for a weekend dose. I know when we talk about weekend dose, it's usually the dose is higher than your daily dose, right? Because you're trying to calculate the dose for the whole week, every per day dose for the whole week, and then you kind of divide that into 2 days, into 2, so you can use it for 2 days in a week. So that's why the dose is going to be higher. And then here, the maximum dose that we typically use is 250 milligram per day of prednisone and 300 milligram per day of deflazacort or Emflaza. For vamorolone, we have no information yet on the weekend dosing. We just don't have data or experience on that yet. All right. I know I saw a couple of questions came through, but we'll just kind of finish this and we'll address the questions. All right, so this is just, sorry about the spelling mistake here up there. This is just kind of showing you, there are studies. I'm not going to get into details. We all know that deflazacort improved muscle strength compared to placebo, meaning someone who took a sugar pill between 12 and 52 weeks. So this one is also comparing deflazacort and Emflaza with prednisone. Actually, patients on deflazacort performed better than those on prednisone in muscle strength scoring over 52-week period. Again, here this black line here that you guys see is placebo, meaning who took sugar pill. So this is this gray line here is who are taking prednisone, and 2 different doses of Emflaza or deflazacort being tried. And this solid red line is the one that we use. If you look at the week 52, there's a clear difference between the ones who are taking prednisone and the one who are taking deflazacort. So this deflazacort is proven to be slightly better than prednisone in preserving muscle strength. And again, this is another study which also compared prednisone versus Emflaza or deflazacort, and it has showed preservation of function across 3 key milestones compared to prednisone. Again, 2.1-year delay in age at loss of ability to stand from supine, standing up from laying down. Same thing with loss of ambulation, and also the age at when they lose their hand to mouth function, bringing their hand to the mouth. So again, and just data from multiple studies and real world experience showing that deflazacort might be better. This is also not just motor outcomes, also has shown some improvements in the breathing, the ejection, in the pulmonary function test, which is the FVC. And then there's also, if you look at the scoliosis, when do they actually get scoliosis? So patients on deflazacort actually develop scoliosis at significantly older ages than those on prednisone. All right, and then this is the data on vamorolone, is the Agamree, which they use 2 different doses, like 2 milligram per kilogram per day, and then 6 milligram per kilogram per day. This is low dose, high dose, and then they compared with placebo. And of course, we know vamorolone is effective. It improved standing speed compared to placebo over 24 weeks. This is a phase 2 study. And then, there's also, we have other data available. When you look at the phase 3, the primary endpoint and the secondary endpoints, meaning looking at the motor function, were met. So we know Agamree is actually effective compared to placebo. And of course, the 6 milligram per kilogram per day dose is actually better than the low dose, the 2 milligram per kilogram per day. So we don't have any comparison of effectiveness, at least available with Emflaza yet. Then we know that the benefits of vamorolone. Again, vamorolone is also a steroid, right? When you they have compared with prednisone in terms of side effects. I don't think the data with comparison with Emflaza is available yet. But what we know that some of the benefits would be the vertebral fracture burden seems to be lower. The bone lower on vamorolone compared to deflazacort and prednisone. And also the boys who are on vamorolone, actually they stay tall compared to other steroids. And of course, we don't have long-term data yet, which is being collected right now and in the real world use. And also, I think there might be a study that they're looking at long-term data from that on boys who actually started on vamorolone. And then, of course, we don't have data on the effects on cardiac and pulmonary function yet, but that's also being probably looked at in this long-term study that we are planning, that the company is planning to do. But one can assume, since it's also a steroid, it's probably likely going to have similar effect as other steroids like prednisone or Emflaza or deflazacort. All right, so kind of briefly touch upon weekend dosing, right? So daily dosing is like that's a standard, typical recommended dose, right? In the United States, we use one of the commonly used alternate regimen is the high dose weekend regimen. But there are other countries where they use more of 10 days on, 10 days off. So within a month you take for 10 days, and other 10 days you don't take it, then you take it 10 days. And there's also some other variations we rarely see. Sometimes people use 3 days a week. So that's also the same. But more commonly in the United States is more of 2 days a week, and that happen to be weekend dosing. Again, we talked about, at least for prednisone and Emflaza, we have experience, just the clinical experience being used in the weekend dosing. With vamorolone, we don't have that experience yet, and there's no real guidance yet on how to do that. But I'm sure that will come up at some point when we start using this, because when we started using prednisone and deflazacort at the weekend dosing, we didn't have any idea. We just started using it, and then we built experience from that. I think we talked about how to calculate the dose. Again, it varies. Most of us, how we do is like I said, we take the per milligram per kilogram per day dose. So you multiply by 7, so you have that whole week dose, and then you divide that by 2. All right. So just what do we actually have in terms of actual data from research that talks about daily versus the weekend or alternate dosing, right? So there's not much data actually out there that compares the daily dosing and the weekend dosing. But we do have data on from this study where they actually looked at daily prednisone, daily Emflaza, deflazacort compared with intermittent prednisone, but they looked at more of 10 days on, 10 days off, not actually weekend dosing, but 10 days on, 10 days off. So, so this study had actually shown significant improvement in the ones who actually were taking daily prednisone or daily deflazacort compared to the 10 days on and 10 days off. So the findings support the use of a daily corticosteroid regimen over the intermittent regimen. Now we do have this study that was published by Dr. Connolly and another group, where they actually looked at twice weekly prednisolone in younger boys, like the age between 0.4 years, about around 6 months to 2.5 year old. They enrolled 23 boys, and their dose was 5 milligram per kilogram per dose for 2 days. Was a prednisolone. And here, they used a specific measure to look at their developmental milestones, and the boys who are on this twice weekly prednisolone, they seem to gain more milestones or get better scores on Bailey compared to natural history, meaning boys who are not taking Duchenne boys who are not taking this regimen. And actually, all boys maintain their height. They were actually growing, even though they're young. You measure their length and height, so they maintain their height. And they had not developed, again, any Cushingoid features, meaning the facial puffiness and things that you would see with steroids. However, there were about more than half of them actually had weight gain from this too. And we are talking about 12 months, 1 year data on this. Again, this is the only, if I'm missing anything, I don't think so, but this is only available weekend dosing research data available. But there's a lot out there in terms of clinical use, real world use. We use that often on weekend prednisolone and weekend deflazacort. All right. Then there's this whole question of how long do you continue, and is it worth continuing the steroids after the boys get into more sort of kind of later stages, more severe disease, or after they lose ambulations, they stop walking. Is it worth continuing that? Again, it is going to be, the short answer is going to be individualized, right? It's going to vary from patient to patient, kid to kid, boy to boy. It's going to be very individualized based on where they are, the other risk factors. But overall, what research data that we have in hand that can help us make the decision would be, there's this pro-DMD, there was a study that what data we have is here in non-ambulatory patients, steroid use was associated with delayed decline in pulmonary, cardiac, and also upper lung function. Of course, that's shown some improvements with steroid, right? And then similarly with another study called MD StarNet that showed that pulmonary decline was delayed in boys who continued treatment for corticosteroids for more than 1 year after they stopped walking after losing ambulation. And there's also a couple other studies that looked at here boys between 9.8 and 31 years of age. Patients treated with corticosteroids showed higher FVC, meaning the breathing function was high, better compared to the ones who are not taking steroids. Same thing here, also shown some improved respiratory function in boys between 7 and 21 years, though taking corticosteroids. Again, just limited information, limited research data, but still shows that maybe corticosteroids might be beneficial after you lose ambulation. Then again, I kind of touched upon this before. So decision about whether or not to continue corticosteroids beyond loss of ambulation is a complicated one. Of course, we need more data on more studies, but it's going to be individualized based on patients, your risk factors, your situation where you are. But most of our recommendation would be we should continue still beyond losing ambulation, but taking into consideration in terms of risk versus benefits. Then, when we talk about steroids, we always have to talk about the adrenal crisis, how you cannot just stop abruptly, how you have to wean. You always have to talk to your neurologist or endocrinologist in your team to talk about stress dosing, meaning when the kid gets sick, what would you do? Or if they cannot tolerate the oral steroid that they're taking, you need to do stress dosing, give them high dose of other steroids like hydrocortisone or some other steroids to prevent them getting this what we call life-threatening adrenal crisis. I'm sure all of you, if you're on steroids, you should have discussed this with your neurologist or endocrinologist if you have a team, if you have an endocrinologist in the team. I think that's all I have, but I'm happy to take questions, and I see a lot of questions come up here. I really want to be more of Q&A. That's why I kept it short, so there's not a lot available out there anyway. It's more from experience, so we can definitely go through the questions and try to answer them.
Yeah, we definitely have quite a few.
Yeah.
So again, thank you. I think that, like you said, there just isn't a lot of research. So you sharing your experience, I think, is really crucial. Our first question is there a low dose weekend option? Why is weekend dosing so much higher than the daily dosing? And I think you addressed this in terms of you're trying to get all of what you would in the week into that weekend dosing, right?
Yeah, so I think along the same question, I also see one thing that I didn't cover is how do you mitigate the side effects, right? So the first thing, when we put them on a daily steroid first, right? And if there is again, I'll tell you my practice. I typically start them at age 2. When I start them at age 2, I actually go for a weekend dosing, just because it's gonna, they're too young. They have better tolerability when you do this weekend dose. And then once they kind of turn 4, I switch them to daily dosing. Let's say if we do that, and if some side effects, if they're not tolerating it, then you can think about the alternate regimen, which would be the weekend dosing mostly. And right now, most of my discussions is, of course, we use prednisone mainly in the use of prednisone has gone down. Let me put it that way. In the clinical practice, it's more of deflazacort now versus vamorolone, except that when there is a situation that someone wants to be in a gene therapy trial, or when they want to be getting gene therapy, then we have to bring in the prednisone aspect, because the immunosuppressive regimen that we use for the gene therapy, it has to be prednisone. So yeah, when you're dealing with side effects, switching to a weekend dosing at that point would be good. If that still doesn't help, then we have to discuss the other option and see benefits and risk. In terms of why is it always a high dose? Because there's no studies out there that actually tells us what is the right dose, right? So we try to like I said before, we try to calculate the whole week's dose based on this milligram per kilogram per day dose, and then divide that by 2. That's why they're on high dose. Yeah.
And then I have a question here that goes kind of to that. Why is the weekend dosing double what the combined total is for a whole week of daily dosing? It wouldn't be double, it would just be the same,
It's
correct?
the same dose. Yeah, I don't think it would be double. I might have had the maximum dose that we can go up to, but it's not double. Yeah.
Awesome, thank you. So I think
I don't
you've
know if they're talking about the 5 milligram per kilogram per day dose of prednisone in the younger cohort. That's just the dose that Dr. Conley and team picked, and it seemed to work. Yeah.
perfect. What would you, so I think you mentioned this too, I'm just gonna reiterate, in terms of when you would look at daily or weekly, it's if daily is not working for some reason for the family, you would address possible weekend dosing, correct?
Yes, I think when the key is to understand what's actually not working and how can we mitigate that part. Yes.
How effective or risky is it to change a regimen from daily deflazacort into a weekend dose in an early non-ambulatory stage?
Yeah, I think that's a great question. Now my question would be, why do we want to change, number one? So what's making us to think, is it the side effects, or is it the is it weight gain, or is it the bone issues, or is it just I don't like to take it? So we need to get understand what's actually, why do we want to change it, right? And there is still a possibility that it may make worse, but we just don't know. But as long as we are keeping the steroids on, I think we should be okay. But can you tell that if I'm switching now and he's gonna stop walking immediately? I don't think we have the data, but there's still, the risk is still there.
Do you feel like it's common for older people with DMD to transition from daily to weekends? Do you see that commonly?
Yeah, so we sometimes do that if there's excessive weight gain. It's just there's a lot of bone issues going on. I think it's okay. It's acceptable to switch that to weekend dosing for better tolerability, and that kind of applies for also. We talk about. I know I keep bringing up the gene transfer, gene therapies. Again, we talk about, can we stop steroids after gene therapy, right? I don't think we are there yet, but there's definitely, we can consider modifications to the daily regimen or even the dose adjustments. We typically try to increase the dose if they gain weight, match their weight. But in those scenarios, you can just not adjusting, just keep it there, or maybe switching to weekend dosing after gene therapy maybe may not be a bad idea.
Awesome. And I know that this is a question that I've actually heard in the community more than once, because like you said, there's not a lot of information, but what are your thoughts on older symptomatic females trying a steroid to slow down progression?
I think that's a good question. Now, here the complexity here is, what are the symptoms that we're talking about, and what are the symptoms are we addressing here, right? So is it the pain? Is it actually they are weak?
Yeah, I think from my understanding, it would
Uh-huh.
be muscle weakness.
Muscle weakness. I think, I don't think it's a bad idea to try that, because it's a dystrophinopathy. There is dystrophin. I think the pathology is it's kind of the same, right? There's going to be inflammation. There's dystrophin is not there, or maybe it's just it's there. It's kind of similar to your Becker, where we try steroids or not. I think it's not a bad idea. I haven't tried that because I don't see adults. I only see kids, and they're mostly asymptomatic when I follow them, except for the heart part. We don't know if we have that on the on carriers, even for skeletal muscle and also for cardiac muscle. But definitely we do intense cardiac monitoring and cardiac management. And then kind of switching gears from carriers to Becker boys also. There's again not a lot of information on steroids out there, but some practices do just start them on a low dose weekend steroids depending if they're weak. So it's quite variable, and I think we're trying to come up with some sort of expert recommendations or consensus, or also collect more data surrounding this to better inform us in the future.
Yeah, absolutely. Here's one from our chat. Given the lack of literature in the field, would you speak to your clinical experience with weekend dosing relative to behavior and weekend? Well, there's 3 of them, so let's do behavior first.
So weekend dosing, behavior of which one? Are you just prednisone and Emflaza are we talking about?
It just
So
generally,
in
yeah.
general, yeah. So I mean, I think we know from what we have, Emflaza is better for behaviors compared to prednisone. And I think we also have data for vamorolone that it's better for behaviors than prednisone. There's no comparison between Emflaza and vamorolone for behaviors.
Would you say that, and we've talked about this, so I'm going to have you speak to it. Would you say that in your clinical experience that you have seen a difference in weekend dosing in terms of behavior with Emflaza or deflazacort specifically?
So I have seen actually behaviors gotten better after switching from prednisone on daily dosing, and also switching from Emflaza daily dosing to weekend dosing of Emflaza.
Thank you.
Yes.
I think we spoke to the gene therapy piece, and then how long a change in regimen should be given to assess efficacy?
That's a tough question. So I would say at least 6 months, but it's hard. But if you're already seeing like immediate worsening in anything, then I would just bring it up to your neurologist, because I have had experience where kids go on exon skipping agents and families are, hey, like, can we try stopping the steroids and see what happens? Not even switching regimens, actually stopping, and we see immediate decline. When I say immediate, with a matter of a week to 2. So if that's the case, I would. But if you're switching regimens from daily to weekend, at least 6 months, if you go for a 6 months follow-up, you can always look at the functional improvements and what's happening.
Awesome. And then can you elaborate on the efficacy of prednisone in the Dr. Connolly study of weekend dosing?
Yeah, so I think it's they used something, it's a younger kids, right? So we are when it's I think between 6 months and less than 2 years. We typically don't use the modern measures that we used to in the clinics, like North Star or time to stand and things like that. So we use something called Bailey, which assesses different domains of development. How they are crawling, how they are sitting up. So the different domains of development, and you score them. So we do have some data on the natural history in that age group, and those boys with Dr. Conley had some natural history data that were not on steroids. So they looked at those scores. So with that, sorry, something came up on
I ignore it at this point because when I want it to happen, it doesn't happen. And when I don't want it to happen, it happens.
No, that distracted me. So when they compared those scores, so the boys were actually on steroids, the scores were higher. There was statistically significant. There were difference between the natural history scores and the ones who were on steroids, meaning they're better developmental domains. They're gaining milestones better compared to the natural history.
Awesome. And because I think this is super important, there was a follow-up to the weekend dosing and the double dosing. So Facebook group, mom shared her son was on 15 milligrams a day combined, so 105 milligrams a week, and the doctor wants to do 100 and 100. So that's significantly more. What would be your recommendation there?
So if they're switching, I wouldn't switch immediately, double it up at all. I would slowly increase if I want to increase.
Yeah, so my recommendation would be to have them speak to their neurologist and, bring that up about, gradual increase.
Yes.
Perfect.
Agree.
Awesome. I
I can,
think, go ahead.
I know someone had asked about Dr. Connolly's the study. I can also speak to the experience in terms of nationwide. There's still actually there's majority of the patients are on weekend dosing. I can't speak for their experience, but I know that Dr. Connolly has shared this with us that majority of the kids are on actually weekend dosing. They just have to publish if they have any information on the efficacy, meaning how effective it is, how different than daily. But that's just what I've heard from her.
Perfect. Well, thank you. I'm going to give everybody another minute. If there are any other questions, please feel free to put them in there. This is a good question. Are there any benefits to a low dose weekend instead of the high dose?
So I don't know how we are defining the low dose versus high dose. There's no clear definition there, right? I would say something is better than nothing. Just because the amount of data that we have is steroids. My suggestion would be start with daily. If we can't tolerate that, go to the actual high dose weekend regimen. If we still can't tolerate that, instead of stopping, not being on steroids, I would say let's try the low dose.
Perfect. All right. Any other questions? I'll give it about 30 more seconds. I don't see any on Facebook. I don't see any in the chat that we have missed. But as I wait to see if any more come through, again, everybody, I want to thank you for being here and supporting our community webinar series and being here to learn more about weekend dosing. And again, Dr. Panda, I really appreciate you coming in and speaking to your expertise and knowledge. You talked about stress dosing a little bit, but do you want to just touch on that a little bit more?
Yeah,
I think you talked about in your last slide with PJ's
right.
protocol.
Yeah, so there is the protocol which you can obviously access through all of the advocacy organization's website, PPMD, or I don't know if Jett Foundation has it up there too. And you can also talk to your endocrinologist, or neurologist. I think it mainly, again, like we talked about, I need to look at actually the protocol, look at what are the doses and stuff. It's critical that you have that in your hand, even when you go to an outside emergency room with any sort of stress situation that could be being sick, being critically ill, or having any surgeries, all of that.
Would it be different if they were on weekend dosing though, or would it be the same?
So that's a good question. I think as of right now, we still follow the same protocol for weekend dosing of prednisone and Emflaza. So vamorolone, and that's still a question out there. There's a group of endocrinologists who experts in Duchenne. They formed this consortium called Optimize DMD, and they are working on coming up with guidelines in terms of managing this adrenal crisis and stress dosing when we use vamorolone. Again, we don't have data. It's going to be purely expert-based opinion or recommendations.
And what I will again emphasize is that you cannot stress dose vamorolone with vamorolone. And I do know that they are updating PJ's protocol at this time to include vamorolone stress dosing. But I do think it's really important to know that, the stress dosing is the same regardless of if it's weekend dosing or daily dosing.
Or daily dosing, right. Thank you. Good point. You cannot stress dose vamorolone with vamorolone.
Don't do it. And I think that's, something that we've heard now, and this will be our third webinar saying that. So I want to continue to reiterate that because I think that it is something that is not, not as widely known, since this is not necessarily the case with other steroids. So, again, I truly appreciate you being here. Thank you for taking your time. I know you are a busy man, so thank you, thank you, thank you. If anyone does have any questions that we didn't get to or that I missed, or if you think of anything after the fact, I know sometimes we need to process information and then ask questions, please feel free to reach out to me. My email is up here, alexa@jettfoundation.org. Happy to give those to Dr. Panda. And we will hopefully see you again soon. Again, this will be it is recorded, will be on our website later and our YouTube, and it's on Facebook. Julie will be sending you a survey as well as the recording for you once we get up with that. So again, thank you all for being here. Thank you, Dr. Panda, and we will see you all soon.
Awesome. Thank you.